Thank you, Chair. The meeting is now live.
Okay. Hello, everyone. Should we start or should we wait for there's 8 people in the meeting. Should we wait for more to join, or is that probably as many as we're expecting?
Let's start. We're live, so let's go.
Okay, thank you. Right. Good afternoon, everyone. Welcome to Health and Wellbeing Board meeting. Do we have any apologies?
We do. Hold on, just getting them up. Sorry. I know we had apologies from Sonia Johnson, also from Alex Guild, Councillor Karim, Melanie O'Rourke, David Radbourne, and I think that's all. Thank you.
Okay, thank you, Lizzie. All right then, and any declarations of interest, you can read the details of that on point 2 on the agenda. Has anyone got any disclosable pecuniary interests? No? Okay, thank you. Okay, moving on to number 3 now. Are there any urgent items of business?
None notified to me, Chair. Thank you.
Okay, thank you. And then on to point number 4, looking at the minutes from the previous meeting. Is anyone willing to approve these as a correct record of the meeting? Hi, Brian.
Hello.
Happy to do that, or Nicola?
Yeah, I'm happy to do that.
Okay, thank you. All right, and any matters arising from that meeting? I had one question, but Grania isn't on this call. Is she expected?
I'm expecting Grania. Yes, but she's not here yet, no.
All righty, I'll leave it then. That's fine. Any other questions from the minutes?
Nope.
All right, thank you. Then on to agenda item number 6, public participation. I don't believe we have any questions from the public.
Yes, that's correct. We haven't received any today. Thank you.
Okay, thank you very much. Okay, then moving on to agenda item number 7, the Health and Wellbeing Strategy Update. I think it's over to Hema, who's with us. Hi, Hema.
Yeah. Good afternoon, everybody. So this is the usual update to monitor the health and wellbeing delivery through the implementation of the delivery plans. What I wanted to perhaps say is from the feedback we've had last a few health and wellbeing board meetings, and then discussions with our lead from each of the organization, we felt that perhaps we need an oversight group from all the organizations, lead members, who can come together before the Health and Wellbeing Board, and that helps to increase the governance of the structures, because one of the things, how do we feed back into the place committee as well, and how do we ensure that each of the lead can take back things within the organization. That was the recommendation last time, to ensure that if it is still on the agenda for every organization, if there are risks. So the first thing which I wanted to highlight was that improved governance structure with an oversight group. The members of that oversight group, we haven't put names in there, but we have a terms of reference. And the members, I can say, are the leads from each organization. So Helen Single and Richard Freeman from ICS, please, and Mahmouda from the ICS Living Well. And then we've got from Involve, Philip Bell. We've got from BHFT, Louis Noble. So we have got all the leads from each of the organization, which are happy to take that oversight in terms of going back to the organizations. We also discussed within that group how we can improve the dashboard, which was again last year. It was discussed that although it has improved, there is still room for improvement. So in the new dashboard, you will see that we have added what are the key outputs from each of the key tasks, which outcome does it contribute to, improving which outcome, and then the lead organizations and the lead officers, the reg rating and a narrative for each of the reg rating. So I hope that gives a better oversight in terms of all the 51 tasks one of the things that we still are working on, which we can bring to the next one, is we've got the tasks and we've said which outcome it improves. What we need to do is perhaps an attachment to show all the different outcomes and the baseline and the trajectory for the improvement. So that could be an additional piece of work to make sure that the improvement targets are being achieved as well in terms of the indicators. From the dashboard, you will see that most of them are on track, but there are 6 which have been delayed. So they're amber, and 2 which have not started, which are red. The 6 which have been delayed are still, you can see from the work that is in the dashboard, there's a lot of work going on. So it's not that it's not going on, but we, as we said, we want to be flexible and adjust things to what's happening. So some of those delays have been because it's better aligned to another project. So for example, with MSHT, it can be aligned to the Healthy Schools project that we are doing. Similarly, there are others, and some have perhaps been delayed because we want to get more insights. So the 6, unless you want me, I can go through each one of them in detail, or I can wait for people to ask questions on that. So I hope this is a better dashboard and it gives an insight. And in the main, we will always give exception reporting in terms of whether amber or red. But otherwise, I think overall the delivery is still going on, which is good. People are finding that they are able to concentrate and focus on this delivery plan, which I think was maybe because that's what we all wanted, is those improvements. So I'll stop there. Unless there are questions, then I need to pick up and then come back in terms of the conclusions and recommendations.
Okay, are there any questions? I had a question, Hema. I was looking at the priority 5, action 46, which is the Tobacco Alliance one. That it's been delayed because you're setting up an East Berkshire Tobacco Alliance group. And I was just wondering if we needed a stronger focus on young people and single-use disposable vapes and how they're marketed at young people. I mean, I think the public health message about the damage of nicotine, certainly to young people and to to your vascular system as you age, isn't being publicised at all. And I think people feel that vapes are completely harmless. And I think, it'd be really good. I mean, I'm sure it would be nice if there was something going on nationally to prevent single-use vapes from an environmental reason alone. But I just wonder if there's any local strategy or campaign we should be doing there.
Yeah, so we have been working on with young people on as well as schools in terms of the vape. So a survey was undertaken to look at the attitudes of young people in terms of the vapes, what their understanding is, as well as what parents were saying in terms of how do they message, how do they support young people to make sure that they understand the harms. So that's one piece of work. We also are working with our licensing and our environmental health in terms of some of the single use. So there is work already started. I think one of the things when we say it's been delayed is because now there is a plan to have either Pan Berkshire or East Berkshire. So while we continue to do work, we can't have a tobacco control plan on our own. We'll have to have it within the Pan Berkshire, East Berkshire system. But locally, we are already implementing some of these things which will go in the plan.
Okay. I suppose what would be really useful, I think, is if we could at the next meeting have a little summary of what's going on. That would be very useful. Right, sorry, Sue, your hand's up.
Oh, I thought I was second. Sorry, that's fine. So thank you, Hema. It's a really helpful update. I just had a question around line 34 that references the re-establishment of the Berkshire East Health Protection Forum that's currently read at the moment. Is there anything that we can do through the Health and Wellbeing Board to support that? Because it's obviously a pan East Berkshire opportunity. So just really a question as to how we can help progress that from a red to transition to an amber or green.
So we have had some reports from the screening and IMS leads, which are, I think there's, and perhaps Nicola may know that there's a transfer from NHS England to ICB in terms of that function, and they have presented data at borough level. So each of the boroughs, what's the uptake, or it may be across from the ICB. What we want to work with them is to give us perhaps more granular. So if, for example, we may say, oh, 85, but there may be some groups which are not uptaking immunization or screening, which we know happens across. The averages don't tell us the whole story. But because of the transfer that's happening, they have asked us if we could just hold on for a little while till they are settled. And there is some work going nationally in terms of data. We'll have to put some data sharing agreements so they can share more granular work with us. So I think it's, in some ways, it's not the East Berkshire, but it's the what used to be PHE, NHSE screening and IMS teams, which need to deliver that because the data sits with them.
Right. Okay, that's helpful. Thank you.
Well, thank you very much. If we find, we'll definitely come back here. And perhaps, I don't know, Nicola, if you know what's happening with the transfer and if there's something from that angle.
I don't know, Hema, but I can ask. And I just following up, there's two different things, aren't there? The one is, has that group been set up now, the Pan Berkshire group? And then the second thing is it getting the information it needs? So just to double check, Hema, is that group now set up and up and running? So it's not really red in terms of the group not set up. It is set up. It's just got work to do to get the information that it needs, and that's because of the transfer between NHSE and the local ICB. But Chair, I'm happy to bring back an answer to the next meeting about where that transition is up to and the provision of more granular information.
Yeah, thanks. Okay, sorry, Hema, I had one more question. Priority 5 Action 48 was another one where it's green, it's orange, or whatever the category was. And when I was looking at our council plan, I was quite surprised that we've got a 65% rate of obesity, which, when you look at other multiple deprivations, it seems to be a bit of an outlier, really, compared to other things that, other health indicators we've got in the borough. And I was just wondering if we could have some more detail on that in the next meeting as well, and what the plans are there. And also, here's an opportunity when we're starting this. It's part of our council plan to improve our rates of obesity. So it would be good to kind of grab that early and start working on that early. So yeah, it would be good to hear some more on that. Nicola, your hand's up.
Just following on from that, Megan, I guess I always put quite a lot of hope in our partnership work around our healthy weights programme and exercise programme. And I don't know when the last time it was that the Health and Wellbeing Board had an update on that, but those two things are linked together for me. I think if that programme really fulfilled its full potential, that's our partnership approach to trying to reduce that unhealthy weights that we do have within our communities.
Yeah, thank you.
So I think in terms of healthy weights and the population weight management weights 65%. Within the plan, there are other aspects because there are the wider determinants. So we've got the whole system approach to obesity, which was presented in the first one. So that's been completed, and we are now looking at the 4 strategic actions in terms of that. In fact, we will again set up the oversight group, which was there. We are also working with the physical activity in terms of broadening the physical activity, not in terms of broadening it to just across the borough, but also for different populations. So as we know that the Tai Chi, which helps people keep their balance, sitting yoga for those who can't. So there's a lot of work going on, people with long-term conditions. And then also doing a lot in terms of healthy eating. So those programs are ongoing, as is the healthy weights, as Nicola said, in the ICS. What this particular action was, because there are all these different things, but we need to think about the whole pathway. So universal services to support population to keep healthy, to those who are very overweight in terms of how they require perhaps a surgery or etc. So if we NICE guidance suggests to have that pathway so that everybody knows where to feed and how to refer people into the different systems. Even the residents know where to go for. And when you move from one service to another, there is support. And I think that is which is at the moment yellow, but other things which are the wider determinants, weight management, etc., that's going on. But it's coordinating that whole pathway and putting that in place, which is slightly delayed. Because we're hearing from.
Thank you. Thanks, Hema. And obviously it would be really good to have a good understanding of that whole pathway, sort of all of us have an understanding of that pathway and how it should work for people. Okay, thank you. Have you got more to present, Hema, or are you handing over to Louise?
I was going to hand over to Louise, or before I hand over, just make sure that the recommendations, whether the dashboard is now something which we are happy with, so we can, or are there any things, further things people want? And also with the oversight group and the governance, both these need to be approved by the board.
Okay, so the recommendations are approve the amended governance structure for the health and wellbeing strategy delivery with the establishment of a joint oversight group, to approve the draft dashboard for monitoring the progress of the delivery of the strategy by the health and wellbeing board, to note the progress against the actions as set out in the dashboard. Is that right? So we just approve that as a board now. Yeah. Anyone got anything to say on this? Nicola, you're muted.
Yeah, sorry, Hema. When you say dashboard, do you mean the dashboard that we've got in our papers that RAG rates everything?
Yeah, the one which the appendix.
Yeah. So just do we have sort of more quantifiable outcome measures? Because what I'm not seeing in the dashboard, and I know some of these changes will take time, is what's the impact of this work and how we know whether doing these activities is making any difference. And I guess I would expect in a dashboard coming from oversight, even if it's part of an annual update, that something on the actual outcomes would be presented back to us, not just a RAG rating of activities.
So that, as you said, we have said which outcomes it contributes, all this contributes. And as I mentioned, that's another piece of work that we need to take with us. There's so many indicators. We set baselines, as was explained in the last report. We have now set baselines against some of those indicators. So we need to bring those in terms of having the trajectories and the baseline. So that can be monitored as well alongside the actions. But because those are quantifiable, perhaps it will be slightly different. We can't add it to this one, otherwise it just goes too wide and you won't be able to see it. So that's the one which we'll bring next week. Next board meeting, Nicola, because it's important to understand the impact of all of this.
Yeah, so from a personal basis, I'm happy to support and approve this report, but with the understanding that we will get some information at an appropriate time frame around outcomes and impact.
Is that? Oh, sorry, Andrew. Were you trying to say
I was just going to support Nicola in that. I think that's a really good suggestion, so that the recommendations are as recorded with that proviso, so that they're captured in the minutes.
Is it worth adding an extra column on this dashboard on what the measurables are going to be?
So I think we've tried that, and it's because the indicators, we have said which indicators, but what we need from each of the indicator is to give a baseline, and each of them, as you can understand, will have different units, and then say what is the baseline and what is the trajectory against which we will monitor that performance. Because it's not sufficient just to say what the baseline is, but what is our expectation in terms of the impact over 3 years, say what our second year, third year, how much improvement we are seeing, and then review those in line with if there's been good improvement, can we push that a little bit further? And where we haven't got that improvement, why haven't we got that improvement, and what needs to happen? So I think both this tasks, the 51 key actions and outputs, plus that one, both need to be monitored together. But the first thing was, getting those indicators and the meta the data from each of the different sources together. And we have been doing that work, so that has been ongoing, but we need to bring it in a way which is easily explained.
Yeah, I agree with Nicola. I mean, when you look at the outputs, it would be quite good. So, for example, let's look at oh, I just read a good word. Yeah, so this mental health awareness increased in school setting. So obviously it would be good to know how much mental health awareness is going on now and how much we're aiming for. Yeah, so so going forward we approve of it, but with
Additional, yeah.
additional, yeah. Okay, all right, thank you. All right, and then anything else on that before we hand over to Louise? Okay, thank you. Over to you, Louise.
Thank you. So I was invited to come and give a bit of an update on Berkshire Healthcare CAMS and the work we're doing in Berkshire Healthcare CAMS. So I provided a presentation, it's in the pack. I don't know whether people have read it and you'd like to for me to just kind of give you an overview of it and then go straight to questions. Yep. Okay. So basically what the presentation covers is a little bit of an overview of the service, the work that is going on in terms of NHS England having introduced definitions in terms of what access and waiting might look like as a precursor to the work that we're expecting that they will do next year, which will be setting some national access and waiting time standards for CAMS. So in the first instance, it's about making sure that we're all measuring in the same way so that then they're able to implement some standards. What I've also provided you with is some data, which is ICB level data, some of which you may already have sight of. So at the moment, what we're doing is looking at proxy data in terms of waiting time to first contact, waiting time to second contact, and trying to sort of use definitions around what is assessment versus what is treatment. So you've got that information. Some data that shows referrals. We're now able to split referral data for referrals to mental health services from referrals for neurodiversity services from referrals to mental health services, which is really, really helpful. So what that data will show you is what we've really seen as a really dramatic increase in the numbers of young people being referred for assessment in relation to potential neurodiversity, but that actually referrals to mental health services are starting to kind of bottom out at the moment, which is really helpful. We have quite a lot of quality improvement and service transformation work going on. So there are a number of slides that sort of talk you through some of the work we're doing around referral processes, piece of work we're doing with primary care in terms of the implementation of specific mental health roles within primary care practices, because we get a high proportion of referrals coming through to our services from GPs in particular, where those young people are either not presenting with a mental illness or actually they could have been effectively supported by a different type of service or a service commissioned elsewhere, and come into that service in a different route. So we can see there are long delays in accessing care, and if we could get in at that kind of initial starting point and direct those young people to the right place, that would make a significant difference. We've been piloting that in RBWM and it is making a difference already. And some changes to our website and our referral process, which is aimed at at using some intelligent automation processes to create a request for help portal so that people are able to more easily access help through that route. What I've also showed is some information about the Clinical Care Pathways project, which is a project we were implementing last year. And that, if you look at the graph, that will show you the increase in numbers of young people who are now allocated to a specific clinical care pathway, which gives us much richer data on what the needs of the young people accessing our service are, so we can ensure that we've got the right capacity to meet demand for those services. And then we have a whole host of new services that have been developed over a period of time or are being developed. So there's a couple of slides that talks about those and the quality improvement work that we're doing around, for example, our crisis service. So just as an example, 75% of the young people that present to the acute units that we support in crisis, it's their first contact with our service. They've not come to us through any other route. And actually, the vast majority of those aren't presenting with a diagnosable mental disorder. So that data is really helpful then in terms of being able to understand what the needs are of those young people. How do they get to A&E, and how can we work with system partners to support and intervene at an earlier point? And that data was discussed with colleagues in the Bracknell Self-Harm Project group last week or the week before, I think. So again, really kind of rich data that we're starting to be able to use more effectively as a system. There is a slide on the TEM that talks about the couple of new services coming in over the next couple of months. So children in care, service for children with learning disabilities and mental health difficulties, and also a project we're involved in called the Thames Valley Link project, which hopefully people are aware of, which is a new pilot project being supported by South East Region, NHSE and Health and Justice to support children and young people who are in complex circumstances, complex situations, who often present with risk, but not necessarily with a mental disorder. And we'll all be able to give examples of children and young people that we are, as a system, struggling to support under those circumstances. And then there is a final slide that talks a little bit about the research that is going on within the CAMS service at the moment. We're quite proactive in terms of the research that we do jointly with the University of Reading. So there's a number of research projects that we're involved in that range from looking at how we can improve safety for children, adolescents treated in CAMS, to the Ivy Research Project, which is looking at different models of care for children and young people needing really intensive support. So that's just a kind of very broad overview of what's in the slide pack. I don't know what questions you have, or whether there are specific issues that you want to sort of pick up on from all of that. Andrew.
Oh, sorry, yeah, Andrew.
Okay. Just a couple of queries on questions. So, looking at the graphs, then, so we think that the kind of the requests for services are plateauing. It looks like from the data. So they've been growing over the period of time, but it's starting to sort of bottom out, I think you said.
It looks like it from a mental health perspective, yes. So
Yeah.
the numbers of referrals coming in through our front door are still increasing quite dramatically, but it looks as though the majority of that growth over the last couple of years has been more for neurodiversity assessments rather than mental illness.
Yeah, and it's really helpful to see it broken down with the Frimley and then in the three local authority areas. Could you just explain a bit more about the pilot that you've done with Windsor and Maidenhead, and whether it's going to be rolled out to other localities?
Yeah, so we've done it. So in terms of the pilot that we've done with RBWM, what we identified was that we still had really, really high numbers of referrals coming in through our Berkshire Healthcare front door for young people who, when we then looked at the referrals and we spoke to those young people, were presenting with needs and difficulties that could have been supported by the MHSTs in a school, or where they actually needed to go to the GEMS service for earlier access to help and support around neurodiversity, or perhaps where counselling or support through youth work services would have been more effective. And we had hoped that in developing the MHSTs and the Getting Help teams, which came into play before the pandemic, that those referrals would have been starting to come in through the locality front door, which is your kind of CYP hub within Bracknell, and that we would have therefore seen a reduction in those referrals coming in through our CPE front door. That didn't really seem to have happened. So we did a little bit of work to try and understand what was going on there and why. And that led into a pilot project within RBWM, where actually we took those referrals that were coming in through our front door and just transferred them after an initial triage. So we triage referrals very, very quickly. They get triaged within urgent referrals within 24 hours. So what we wanted to understand was if we were triaging them as probably kind of low intensity cases, and we transferred them straight down to those services, how many of them actually could then be supported by those services? Were we missing any that kind of did need to come back in through the CAMS front door? And what difference did that make in terms of the journey of the young person? Generally speaking, what we found was the vast majority of those referrals did meet the criteria for being looked at an earlier point. And when we looked at the patient journey, there was an average of 40 days that those referrals, because they were sort of routine for CAMS services, there was a delay of on average 40 days if they came through our front door in terms of our processes. Whereas if they'd gone straight into the RBWM front door, they were being seen much more quickly. What we also found was that the way some of the processes were set up with partner agencies, and particularly with getting referrals, with people feeling able to refer in, we couldn't work out whether those young people had followed the advice and guidance and actually ended up in the right service at the end of the day. So with the RBWM pilot, what we found was we were able to reduce that 40-day delay, and also we could be confident that the children and young people were actually getting to the right services, the right help. So we've been doing a couple of things to roll that out. One is actually more closely working with local authority colleagues to try and improve the information on our website, the information on your website, the referral processes, and the confidence of people to refer through the locality systems. And there's some further work we really want to look at with you over the coming months to improve that even more. And then we are looking at rolling that process out whereby the referrals are transferred straight through if they're identified as being low level to Bracknell and then to Slough. It's been limited a little bit by workforce capacity issues in the MHSTs and the Getting Help teams, but it is already starting and it will be ramping up from January.
And then, sorry, not to hog, my just final one. That's really helpful. Thank you. In terms of the stuff you're talking about, the research, do you involve partners in that research? Is it wholly your service with Reading University or whomever? I'm just thinking of whether there's anything where we could help as a system.
We do involve partners in research, yes, and I'm sure there will be opportunities where we could work more collaboratively together. So I don't have any examples at the top of my mind at the moment, but historically we have tended to be involved as partners in research projects that are coming down through, for example, the National Institute for Health Research, and they may be being led by the Ivy project, for example, is led by South London and the Maudsley, and we will be a site that is contributing. But over the last couple of years, we've been really ramping up our own internal research portfolio, identifying and kind of bringing in funding and starting to develop our own research. And certainly in the way that we're thinking about how we need to tackle the equality diversity issues, I think there will be real opportunities to look at how we could do some broader, more collaborative research with partner agencies moving forwards.
Yeah. Okay, great, thank you.
Nicola?
Hi, Louise. I'm Nicola Arey. I work for the ICB. So thank you so much for coming. It was really useful to have a bit more insight into what you're doing and have that visibility. You mentioned about, making sure that you build the capacity to meet demand, but I know will also be part of your strategy to try and reduce the demand through early intervention and prevention. And I guess that's where services that are on the footprint of Bracknell Forest come in, because some of that early intervention and prevention is done by partners who live and work within Bracknell Forest. How far do you think that we've got the data that helps us work in partnership and track where the gaps are, and whether when we do things at a Bracknell Forest footprint, it is having impact on the demand that you get? Most of the data I still see about CAMS is either at a BHFT footprint or an ICB footprint, which doesn't allow us to match and to judge how that partnership working is happening. I wondered if you thought that lack of visibility of data at a Bracknell Forest footprint is preventing opportunities for working together around early intervention and partnership and tracking whether it's having an impact?
Not necessarily, Nicola. I mean, I think there are all sorts of data opportunities we have now through things like connected care and through the Oxwell survey, for example, that will provide us with the data that is going to be more helpful in terms of that prevention and early intervention agenda. I mean, we don't track data broken down by individual local authority level for a lot of our services because the numbers are small and it tends to not be particularly meaningful. But at the locality level, in terms of the Getting Help teams and the MHSTs, we do. And that's the data that's much more meaningful in terms of understanding the kind of where our opportunities might be. I mean, we do also look at whether on where we might be seeing oddities. So for example, I don't think any data has actually shown this, but for example, within the eating disorder service, we know that we have quite high numbers of young people presenting quite late and at a very unwell stage, and where we need to then be able to then basically we're sending those young people almost straight up into an acute paediatric bed, and that we could have prevented that more effectively if we'd had that information earlier. And so we can do deep dives when we get that kind of oddity in the data, and then we would be looking at actually, are there particular schools that we need to be targeting in terms of the schools work that we're doing. So yeah, it doesn't at the moment feel like it's a particular barrier because we have so many other sources of very, very rich data.
Thank you. Grania, you had your hand up.
Yes, thank you. And mine was a similar question, and it was just the observation of Bracknell Forest is Bracknell Forest, and we have residents and children and young people in Bracknell Forest. And it's vitally important that we're able to monitor the impact of all services on our children and young people in order to do that effectively through our plans, health and wellbeing strategy, through our children and young people plan, that we have the data at a Bracknell Forest level. So I just wanted to reiterate that our need, not desire, to be able to monitor all services at a Bracknell Forest level. Now, we have spoken to Tracy Faraday-Drake, who's Executive Director for Children and Young People in the ICB, who has committed to giving us increased access to Bracknell Forest level data relating to CAMHS. I'm mindful that the activity and the metrics are going to be changing nationally, etc. But it's something really important that we, if the providers aren't monitoring it, that we're still able to get it through whatever commission support enables us to factor that in. You'll see moving into the next one, but you'll see, I'll have to do the data comment now because it is linked to the next one, the metrics that we need to monitor for the effective implementation and monitoring the outcomes within our children and young people plan, which is linked to the health and wellbeing strategy. It's really important that we do get that data. It's really important for our regulators when we have Ofsted and CQC joint inspections that we can provide data. So for a whole range of reasons, Bracknell Forest does exist as a place, and it's really important that we're able to monitor the impact, the take-up and responsiveness of people using services. The question that you just asked, Nicola, some of the problems that we've had in relation to social, emotional, mental health and our understanding of the children, for example, those with the HCPs, Education, Health and Care Plan, sorry. It's really important that we do understand those needs. We have a really high proportion of those individuals who are needing specialist education with social, emotional, mental health. So in terms of having that awareness of those rich data sets and us collaborating to understand how we use that data for the purpose of planning, is essential and important, and something that we do want to continue to factor into the work that we do in the Children and Young People Partnership Board.
Thank you, Grania. And Hema, you've got your hand up there as well.
Yeah, I just wanted to add that, I echo what both Nicola and Grania has said. And it's not also just about at borough level. But one of the things what is important is understanding where the risk is higher within a borough. So, you need to understand that if you're going to support or target services. And as part of that, Louise has been involved in this. We have been discussing to look at some of the risk factors for low emotional health. How do we map that across Bracknell Forest? And the three things we've been looking at is low emotional health, disordered eating, and gosh, I forgot the third one, Nicola. Sorry, Louise. But we have been discussing that with CSU to look at how do we get all the different data sets, and how do we then map that for Bracknell Forest, across Bracknell Forest, and that those maps then can be used by us to look at where this is. And this came on the back of the last Health and Wellbeing Board, where they presented the adult maps, adult low emotional health. So we've been working with CSU to look at exactly that, because otherwise it's difficult. Bracknell Forest is a place, and within Bracknell Forest, there are different populations and differences in those populations. So we really need to understand that Bracknell Forest is a place, what are the issues and what are the risk factors. And it's important we as a whole, I think all the agencies work together on this, because otherwise we will never understand what Bracknell Forest needs are for the local communities.
And I'm sure that Tracy is working with relevant colleagues within the trust in terms of any data that might need to come from the trust, but also a lot of what you just talked about is data that's available already and or through connected care. So yeah, that will be an ongoing work in progress, I'm guessing.
Okay, thank you. Any more questions on Louise's presentation? All right, thanks guys. So now if we move on to agenda point 8, which is the Bracknell Forest Partnership Plans, and I think that's you, Nicola, presenting.
Yeah, I think Gráinne and I are going to do a bit of a double act. I was going to talk through the adult plan we've got, and Gráinne is going to do the children's one. So you've all received the plan. I've got a very small presentation to share. If I only knew how to share presentations on Zoom rather than share screen. Here we go. You can see all my work out which presentation it is. Okay, I won't worry about sharing it, but just to give a little bit of an introduction, then I'll take comments. So this health and care plan is the first time we've put down on paper a joint plan between us around our adult services. It's a 2-year plan. It's not everything we do together, but it's those priority areas that we've committed to working on together. I know the document mentions the ICB and Bracknell Forest Council, but it does involve our other partners, including our voluntary and third sector. It is going to become increasingly important when we have to bring in other people to help us deliver our plans, that we're really clear on what our priorities are. So that's the purpose of it. There's a little bit extra in there about a new way of looking at reducing health inequalities that the NHS has called Core 20+5, and you'll see some actions around that. It does align with all the other things that we have to bear in mind, whether that's the ICS strategy or the council plans or our health and wellbeing strategy, and it will continuously be adjusted if any of those plans change in a key priority area. So do be rest assured that we will reflect the new priorities of the Bracknell Forest Council plan within this. So really, it has been approved through the Place Board. It's here for visibility and for you to note and comment on, and just to highlight the level of commitment that we have amongst partners to jointly improving services for our adult population. So I don't know if there's any questions, Chair, or any points of clarification that anybody would like.
Sorry, it's taking a while to load on mine. With regards to the Core 20+5, I've just learnt about this in my course. And what are we choosing as our sort of +5? What are our kind of local challenges?
Yeah, so we're the system has so the whole of the ICS has introduced 2+ areas, and those were areas that were coming through from Bracknell Forest as well, so that's great. And those 2 areas are carers and individuals with learning difficulties. And the way it works is the plus areas, so things like cancer, for example, what we'll make sure that we're doing is reducing the inequalities that, for example, people with a learning difficulty have in terms of uptake of cancer screening. So it's really a combination between the plus and the 5 that is the approach. And then, of course, specific to Bracknell Forest, when we look at our individuals who live in areas of deprivation, those are small numbers for us, but we are going to do a specific deep dive into those communities and individuals that live within Bracknell Forest. So carers and people with learning difficulties. Chair.
All right, thank you. And Andrew?
Yeah, sorry, from looking at the papers, I don't think that the adult plan is in here.
It came as a separate
is it on as a separate?
Yeah.
It might be on a different part of the agenda.
Do you want me to send it to you again, Andrew? It was a supplementary.
Yeah, no, sorry, I've seen the supplementary. You're right, it's in the second part. So, no, I was just worrying it wasn't there and we would need to circulate it, but you've done it, so it's fine. Ignore me.
And I know sometimes these plans take a little while to absorb. So if there's any comments, Gráinne and I'd be happy to receive those after the meeting as well, or if you want any clarity on anything.
Thank you. I must admit I hadn't read it and I was panicking there. But yeah, thank you, Nicola. I'll have a look at it and give some feedback. All right.
Would it be helpful if I just sort of outline what the priority areas are if people haven't read them? Just, I mean, it'll take 30 seconds.
Yeah.
Yeah. So there's a real emphasis on prevention. So there's a whole section on preventative activities would take place together. How we're trying to be more proactive, so not wait for people to need hospitalization or acute services, and also some work around specific groups within our population to target our health approaches. So those are the main sort of areas of work, and that's detailed more in the plan. So I'll leave that. I'll leave that with you.
I can see Gráinne's got a hand up, and then Hema.
Yeah, just as supplementary. So sometimes health and care appears so separate for people, and what the plan's been able to do is show all of the health activity that's taking place within this period, and we've been able to overlay, well, this is the social care activity that's in this period as well. So a lot of the activity that's in there from social care is in the service plans, and then for 24-25 they'll continue to be in the service plans and get updated. So, for example, the integrated carers strategy, all age carers strategy is mentioned in the document that came to executive in September this year, going out to consultation. So it's just to bring some of it to life for you in terms of those things that we've agreed to do together. So it's not about something that's completely new, but it's about us actually committing to work together proactively on some of those initiatives. So it gives us a shared plan. It's a helpful plan for the purposes of our regulators as well, when they come in and see how we've articulated our ambition for joint working. So it is a plan and not a strategy.
Hema?
Yeah, I just wanted to perhaps comment on the Core 20 Plus, because they use IMD, that's Index of Multiple Deprivation, to look at those which are most deprived. And you're right, Nicola, that we don't, Bracknell Forest doesn't fall in the bottom 20 or 40%. However, what we need to be mindful, as we discussed previously, that Bracknell Forest is a place and it has got distinct characteristics. When you look at the different domains, because the Index of Multiple Deprivation is made up of different domains. Now, because of Bracknell Forest and 40% of it is green, outdoor spaces and all that, we rank high. However, when you look at income deprivation, you can see that there are more people in those ranked in income deprivation. And I think we need to be mindful of that and not just go on the overall IMD20, but look at income deprivation. And that was 2019, but we know there's more data on income deprivation. And our welfare team obviously use some sort of a tracker kind of to look at those who are on low income and struggling. So it will be useful for us to use that data as well when we think about Core 20 Plus, is to look at income deprivation.
Yeah, Hema, that's really helpful and an insight that I wasn't aware of. So it might be that we can run the data in a different way and just see what a difference that makes to the numbers that we're looking at. Remembering that a lot of people that have income deprivation, we will pick up through the 5 disease groups as well, because they will unfortunately be the cohort that do have higher levels of respiratory issues, cancer, etc. So we will pick them up, but that's really helpful, Hema. Thank you.
Thank you. Sue?
Thank you, Chair. And thank you for both. I'm going to make a general comment about both plans, if I may, and welcome them both, and welcome them as a joint piece of work, because I think that sends a very, very strong message. And as a local authority, we've just recently approved our council plan through our full council last week. And I can very much see some of those key themes from our council plan being reflected through these plans, which is great to see, because there's obviously then a clear thread between our collective system leadership approach in looking at what we're trying to deliver on the ground. And then my second point is a gentle plea around just making sure that these documents, because they are so valuable, that we design them in such a way that they're accessible. So some of the graphics, some of the images are clearly very powerful, but I think we just need to, well, they hold a lot of information, but I think with the EDI agenda, I think just making sure that the information that we're reflecting is as accessible as possible would be really helpful. Thank you. Great piece of work.
Thanks very much. That's really useful feedback. And I will take away and think about how we do that in terms of whether we need a more accessible sort of summary document alongside this to make it more accessible for more people, and the different ways that we can do that. So yeah, thank you.
Can I just say, I mean, we've got the health and wellbeing strategy, we've got this adult plan, children's plan, we've also got our council plan. Has anyone kind of cross-referenced and make sure that they're all?
Yeah, they've all been. We always cross-reference because there's more plans than that as well. And I think what we're trying to do is, especially when we're asking for reporting or monitoring, try and find a way of doing that once if the same thing is going through multiple routes.
Yes. Okay. Fantastic. All right. Thank you. So any more questions about the adult strategy? Okay, should we move on to, Grania, you've got your hand up.
No, I'll move on to the children's, but I think in the context of the adults one, it is a very wordy document, and the document itself, it serves a purpose in terms of being a document that outlines the detail, but you are right, in its current form, it's not suitable for a public audience in the way that'd be helpful and useful. Some people might be interested in reading it, but I think in the context of where we're at with trying to finalise it and get the detailed plans, etc., we felt that we needed to bring them both here. So the children one is slightly more accessible, but still in the same way, it's not that digestible for somebody who just wants to know what the headlines are, etc. So fully accept the point. So thank you for that. But please be reassured that we're aware of that already. In the context of children with people plan, so we have a duty to collaborate on both adults and children's, and the Children Young People Partnership Board is a board which is a formal subgroup of the Health and Wellbeing Board. So that is why it's supported underneath. So some of the priority areas within the health and wellbeing strategy are delivered through the Children Young People partnership board. So it's not a decision-making board. It doesn't have any delegation. It is a forum for collaboration as indicated in the various legal frameworks. So the Children Young People Plan, our last plan, finished in 2022. It's taken us a little bit of time to actually create an updated one, and more specifically about the metrics. So the key priority areas have come out of our existing plans, as you can see. 2 of them relate to SEND, 1 ambition for care leavers, tackling health inequalities, etc. So I will just read those if you just give me a moment just to pull people's attention to them. So I'm still on the adults plan. A little bit before I get to that about our way, how have we prepared this? So it has had engagement, involvement, co-production with a range of people, parent carer forum, and young people through the various different providers, organisations who support the Children Young People Partnership Board activity, because it's a group of partners all coming together in the way that Nicola described, but including our education leaders too. You will see that. So just let me go back to the priority areas. So we've got 5 priority areas that are listed. Tackling health inequalities 1, and you'll see the detail of that in the plan in terms of what we're aiming to achieve and the metrics. So, and how do we know? We give quite a lot more time on this one in terms of being able to measure and report on, well, how do we know that we're delivering the ambition, etc. So the first one, tackling health inequalities, and you'll see a number of metrics and indicators that we're building into a dashboard. For each of the years, we have got updated actions for the years. So what activity are we delivering in this year, and how will we measure that has been achieved in the short, medium and longer term in terms of the metrics and dashboard. Stronger support for emotional wellbeing and mental health. You'll see the key priority areas there and indicators for success, and we now have a more detailed plan for the year. Improve life chances for care leavers. You'll be aware that we had a Ofsted inspection, full Ofsted inspection for children's social care last year, and we achieved good as part of our children looked after and care leavers. So we wanted it to be more aspirational, especially about their outcomes. So that's why we've collectively identified that as an area for joint focus, and obviously improving services for our young people with educational needs and disabilities, a priority area, and as well improving educational outcomes for all pupils, including those who are vulnerable and those pupils with special educational needs and disabilities. So hopefully everybody around the table will recognise that as being completely in line with our individual and collective priorities, and a lot of the sub-actions and metrics are broad partnership. So I think that we're very comfortable with what's been identified as a partnership, the partnership priorities. We already oversee and receive the regular updates on the SEND, Special Educational Needs and Disabilities Improvement Plan, and from the Partnership Board as a partnership. So it does already get quite a lot of attention from the partnership in that meeting. And I'll stop there, Chair.
Thank you, Grania. Are there any questions? I think it looks like a really good document. Thank you very much. And it seems that everything's covered. Brilliant. Okay. In that case, I think Bex has joined us. Are you next on the agenda, Bex?
Sorry, Chair. Sorry, Chair. Hema has her hand up.
Oh, sorry, Hema.
It's okay. Yeah. I just wanted to say that both the adult and the children, well, adult I hadn't read previously, but the children I had, and it's very good. It complements the health and well-being strategy very well, and picks up some of the things that we could do jointly. And I know Shamaki and Tom have been working together to look at how we do the indicators dashboard. So, going back to the question, it's how they're aligned, and some of the things that we want to deliver through health and well-being strategy, but some of the inequalities are so well picked up by the children and young people's plan. So I think that really is a good fit for what we want to see in terms of improvement from a population level as well. So good piece of work and very much appreciated.
Thank you. Okay. Thank you very much. Any further questions on the partnership plans? Okay. All right. All right. So welcome, Rebecca.
Hello there. Right. You'll see how awful I am with Zoom now because I need to share my screen. I think I figured it out.
Luck.
Thank you. So, oh no, maybe I haven't. Apologies.
There is a share screen button on mine. I don't know if
Oh,
you
here
have
we go. Yeah,
possible.
that's the one. It's as simple as that. Thank you. Yeah. There we go. Right. Hopefully you can see my screen and the slides. Is that visible?
Yes.
Yeah.
Yeah. We've got it. Yeah.
Oh, you got it in the. Sorry. This is, yeah, trying to. I think because of Zoom, it's not. Sorry.
If it's not easily fixable, I mean, I can read that. Can everyone else read that? Okay.
Yeah.
Yeah, I don't know how to. Yeah, it's not letting me do anything with this at the moment, unfortunately. But I will speak to the slides and they'll be available after today. So hi there. Thanks, Councillor Wright, for bringing me in. I'm Bex Willens. I'm consultant in public health for the Berkshire East Public Health Hub. We've recently drafted a new Berkshire East Sexual and Reproductive Health Needs Assessment, which we've worked on during the course of this year. So I'm here today really to present the key findings from that piece of work. Apologies. There we go. So in terms of national context, we still have quite a complex commissioning landscape when it comes to sexual and reproductive health. This diagram's a little out of date, but it is the still the clearest one in terms of dividing up what NHS commissioners are responsible for versus local authorities. So basically through the public health grant funding, local authorities are required to fund access to STI testing, HIV testing and comprehensive sexual health services, which are typically delivered by a specialist
Bex,
provider.
I think we can see your browser rather than the slides. Would you mind just minimizing the Zoom meeting and web?
Yes, I think it's possibly because I'm Zoom share. Why is this? Sorry about this. Right, is that better?
No,
I think you might need to stop sharing, Bex, and start again just to see if it comes back up.
Okay, let's try one more time.
If you'd rather send the slides to me and I can share them for
Thank you. Who's offering to do that?
Oh, sorry, that was Lizzie. Lizzie Rich.
Lizzie, thank you, Lizzie. I'll do that because you don't want to be wasting your time on
no
the
problem.
technical glitch. Am I still sharing at this point?
No,
you're fine.
Good. Right, I'll send them and then I'll carry on talking and then we can get on with the show. Come on. There we go, Lizzie. It's coming through to you now. Great. Okay, so as I was saying, basically national context, local authorities have to commission some sexual reproductive health provision, but NHS bodies, including ICBs and NHS England, are still responsible for commissioning a lot of the rest of sexual and reproductive health. And that's particularly important at the moment with the introduction of the Women's Health Strategy, which has put much more emphasis on women's reproductive health, moving the discussions away from just a focus on contraception to other aspects important to women's reproductive health across the life course, such as menopause or fertility or gynecological matters that affect people's health and well-being. Now, that's important because there's been lots published about sexual reproductive health, and thanks, Lizzie. So if we go on to the second slide, thanks. In effect, we still need to work together effectively, and we are seeing increased demand in specialist sexual reproductive health services nationally and locally, and increases in the rates of STIs. So although there's some really good news stories, we've managed to drastically reduce the number of new HIV diagnoses, reduce under 18 conceptions. There are still some challenges. Next slide, please. Now, for Bracknell Forest, before embarking on this health needs assessment, we already knew that there are some areas for improvement and some areas we're already doing really well. So on this diagram, if Bracknell is showing as green, a green dot, it means that you're doing statistically significantly better than either the national average or the benchmark, depending on how that indicator is measured. And if it's a red, it means significantly worse than, again, the England average or the benchmark. So the two areas I'll highlight, we already knew that in terms of identifying young women aged 15 to 24 with chlamydia, we're significantly below the benchmark of 3,250 diagnoses per 100,000 population a year, and we're also screening far fewer young people than the national average. So we knew regarding young people's sexual health, particularly with chlamydia screening, there was a need to improve that offer. And the other one was around HIV late diagnosis, where we're significantly lower than the benchmark, which is an ambition to have fewer than 25% of new HIV diagnoses in the UK diagnosed late. Now that is really important. We work on HIV, but we are doing better than a lot of our other areas in our testing offer. And that statistic is partly skewed by the low prevalence of HIV locally. So it's basically quite hard to find those remaining people who are undiagnosed. Now, in terms of the current services available, the specialist provider is with Berkshire Healthcare Foundation Trust, and at the time of writing the H&A, the contract for that was due to expire end of June 2024. So we wanted this health needs assessment largely to inform the updates to the service specification for that, which it has. And I'm pleased to let the Health and Wellbeing Board know today that the Director Award offer has been accepted and signed. So we've secured provision with BHFT now to the end of June 2026. So that will continue. Berkshire Healthcare Foundation Trust also subcontract SH24, who provide access to online test kits. We have 8 of the 11 GP practices in Bracknell providing long-acting reversible contraception alongside their wider contraceptive offer they're commissioned to deliver with NHS England. We only have one pharmacy in Bracknell currently delivering an emergency hormonal contraception service. That service is not really about just the provision of EHC because people can buy that over the counters. It's more an opportunity for health promotion and safeguarding young women who are coming forward saying they need emergency contraception. And historically in Berkshire East, we've had really low interest in pharmacies in providing that service. So we are doing some work with the ICB's community pharmacy lead and our local pharmaceutical committee to look at what might be a stronger offer in that setting. We also have a website called Safe Sex Berkshire, which provides signposting and health promotion. And then the youth team in Bracknell Forest Council are working with 3 secondary schools. And then there are a number of other local providers providing NHS commission services as listed there. Next slide, please. Thanks. So the part 1 of the health needs assessment was focused around 3 key themes: contraception, STIs and HIV, because they're largely the stuff that the local authority needs to commission. And our intention is to work on a second part to the health needs assessment in collaboration with NHS partners to make sure this assessment of need is much more holistic and enables partnership working. So regarding contraception, the main finding we identified relevant across Berkshire East and relevant in Bracknell as well was that ethnicity was the main population characteristic that most affected women's access to contraceptive services. So this diagram is showing data for Berkshire East. The blue columns represent the proportion of the female population aged 0 to 49 split by ethnicity. Reason 0 to 49 is used is just because of the way the census data is divided up, but it's the best proxy we had. Orange bars represent GP prescriptions for contraception split by ethnicity, and grey by the specialist setting. And overall, what we found was uptake among women of Asian or Asian British ethnicity was much lower than all other ethnic groups. And then we saw a tendency for some of the other ethnic minority groups to have a higher likelihood of accessing contraception from the specialist settings. And that finding does seem to tally with some of the national evidence about choices around settings in which contraception is accessed. Now, patient choice is absolutely important, and we know that just under half of pregnancies in this country, women have been ambivalent, undecided whether or not they wish to become pregnant, and that might be a factor alongside other beliefs. But what we do want to make sure is that women who want to access contraception and contraceptive advice feel able to do so. So if we can have the next slide, please. The reason we were quite keen to explore ethnicity further was, again, we already knew from the Frimley perinatal equity strategy that ethnicity was another prominent theme there. For instance, we know a high proportion of deliveries in Frimley are born to mothers from Black, Asian and ethnic minority groups. And that's fine, but we want healthy outcomes for these mothers and for their babies. And we know that, for instance, the BMI rates, the body mass index rates of Black British mothers are higher among that ethnic group coming into the Frimley services. Women of Asian British and Black British ethnicities have a higher risk of having a preterm birth. In our termination of pregnancy data, so that's what TOPS means, termination of pregnancies, again reflecting national patterns, but we see women from Black and Black British backgrounds disproportionately more likely to have a termination and also a repeat termination. And we also noticed that our GP prescriptions of EHC, emergency hormonal contraception, were higher for that ethnic minority too. Sorry, if it's possible to go back a slide. So we can't infer any kind of causal relationships here, and we are not trying to suggest that there is a barrier to access, but we definitely need to work with the Frimley Integrated Care Board's local maternity and neonatal system board to understand the preconception care offered to women from ethnic minority populations. That's acknowledging both the need to advise on contraception, but if people are choosing not to access contraception, the sorts of things they could be doing to prepare for a healthy pregnancy should that happen. Next slide, please. This slide is just to summarise what we identified regarding LARC contraception. So I mentioned earlier, specifically local authorities fund long-acting reversible contraceptions, things like the contraceptive IUD or implants. The majority of GPs in the area provide LARC, and the map there with the purple, where you see either basically if you see a blob that either says GP or a number, that represents a GP practice. They are the ones offering are based in the more highly densely populated areas, and where the little area to the east of Bracknell Forest that has no GP blob, there is one over the border in RBWM providing LARC. And overall, the total LARC prescription rate's higher than national rates, but it is lower in Bracknell compared to areas with a similar deprivation decile. So if we can go back a slide, I will try and speed up a bit. And that does mean we could be doing a little bit better than we are in terms of ensuring lots of women have access to LARC, because that's the most effective form of contraception if that's what they want to do. Next slide, please. So the next major theme we found, and it's probably no surprise to anyone, was we explored what sites people access in terms of physical sites and online services for specialist sexual reproductive health care. And we see, sorry, we see that historically the most popular sites, back one slide, sorry, Lizzie, were the Skimford Hills Health Centre and in Reading, the Royal Berkshire Hospital. So most Bracknell residents historically have gone to those sites. But since the pandemic, a huge increase in those accessing online sexual health care, and that is currently only for STI testing, and an increase in patients accessing the Slough Clinic. Now, we don't know why exactly that increase in the Slough Clinic what the reasons for that are, but I suspect it's in part because those who are less complex and therefore able to access the online offer are doing so, and those who would have need to have been seen face to face are having to go to the tier 3 site, which is based in Slough, whereas the Skimpertill and Reading sites are offering just a tier 2. So it's just possibly reflecting that less complex patients are going online and the more complex ones are having to go to the tier 3 site, as we'd expect. The reason this is important is that currently our online offer is fairly limited. We're only offering on access to online STI test kits, and there might be a need to consider provision of things like contraception and the quality of our health promotion offer alongside that. Next slide, please. Regarding STI testing rates, the headline message here really is that yes, Bracknell, as the rest of the country have seen, gradually over time there has been an increase in STI testing rates and increase in the number of STIs identified. We've not quite got back to pre-pandemic levels, but anticipate we will. And broadly, our STI testing demand is roughly in line with the proportion of people we find positive. It's not a you can't necessarily there's no standard to explain what exactly those patterns should look like, but broadly we'd expect them to be in line. We're roughly testing the number of people we should be. Our positivity rates are significantly lower than the national rate, but in line with our comparator deprivation decile, and again reflecting national trends, higher among younger people and higher among people from Black British, mixed and white backgrounds. Okay, next slide, please. This is my last findings slide, and there's a lot of data in here on HIV, but just pulling out a few key messages really. Of the people living with HIV, so that's what PLWHIV stands for in Bracknell Forest, the majority or higher proportion are men. The majority are of white or Black African ethnicity, but when we break that down by ethnicity and gender, most people who are white who are living with HIV in Bracknell Forest are men, and most people who are Black African living with HIV in Bracknell Forest are female. The main exposure routes are entirely sorry, not entirely, but the vast majority there are connected to sexual contact, more so men who have sex with men and heterosexual women. And most people living with HIV are entering their middle and later years, which again reflects the fact that we've, as a country, been successful in reducing the number of new HIV transmissions, new HIV diagnosis. And a lot of people living with HIV in Bracknell Forest, you'll see the statistics at the bottom there, 98% are receiving antiretroviral therapy. And of those where their viral load was known, 95% basically had a low viral load, which means better health for them, better experience of health and well-being, and lower risk of transmission. When we compared that data to those accessing HIV testing and PrEP, we found Bracknell do really well, and actually we do really well across Berkshire East in terms of the proportion of people testing for HIV across all our demographic groups. So that is a good news story, but we haven't yet returned to pre-pandemic test rates. With regarding to PrEP access, so PrEP is pre-exposure prophylaxis. It's something people can take if they're not HIV positive, but at higher risk than the general population of acquiring it. It reduces the risk of contracting HIV. So Bracknell are doing similarly to the national average in terms of people who are eligible taking up the offer of PrEP, about 63%. But what we don't know yet is whether there's an inequality in the groups who are eligible, who are accessing it. What we do know is the majority of people accessing it are men, gay or bisexual men who have sex with men. The majority are from white ethnic groups, but much lower uptake among Black British populations, and no Black or Black British women receive PrEP. Now, that could be because none eligible came through the service, but at the moment that is a gap in our understanding and something we're working with BHFT to understand. Simply because looking at those living with HIV in our area, we would like to understand PrEP need and HIV testing need among our Black African population largely. Next slide, which I believe is the final one. Yes, So the main areas we've identified for development, and these were discussed at a workshop we held in May of this year with a range of professionals, and this has also informed our new service specification with Berkshire Healthcare Foundation Trust, is a review of our design of our digital sexual reproductive health offer. So that includes everything from the websites we signpost people to, how we approach health promotion and things like telemedicine, what it is we offer online. So is it just STI testing? Do we include things like pregnancy tests or contraception for groups where we think that might be beneficial? And also looking at the patient flows. So we anticipate continued increase in demand for STI testing. So how do we not how do we make sure that those who need face-to-face access continue to have that, and those who choose to access it online have a really good quality offer? If you click again, Lizzie, I think you'll come up with the next priority area. We also identified a number of priority groups in the health needs assessment where we feel there's a need to do some engagement work to understand their needs better and design specific services or service responses around them. That includes young people, people who have neurodiversity, some ethnic minority populations, and then refugees and asylum seekers. And we've already begun work to explore the views of local children, young people, and professionals that work with the more vulnerable groups. And BHFT have been successful in securing funding to work with refugees and asylum seekers to explore access to HIV testing and PrEP, which is great news. Next bullet, please. Our H&A workshop in May, the stakeholders there felt it would be really important to develop a local engagement strategy so that when we are engaging with the groups listed above, it's not a one-off consultation exercise, but that we have an ongoing plan about how to keep engaged and make sure we're monitoring inequalities in access and their views over time. Next bullet, please. Another recommendation from the May workshop was that local providers are keen to work with us as commissioners to develop something like a sexual health network where we can speak together about patient pathways, care pathways. And I think that would help some of the work I described earlier, where we look at what's funded by NHS commissioners and ourselves to make sure for the patient their care is well joined up. And last two bullet points, you can click twice, Lizzie, and we're done. Thank you. So we're also working with the Integrated Care Board on the Women's Health agenda. Some of you might have heard of Women's Health Hubs, and that is something where we will need to work together to make sure that whatever reason a person might be accessing contraception or have some reproductive health need, they can go to somewhere where they can trust they're getting the best advice and care that's joined up. And the last one is HIV prevention, and I sort of spoke to that the last slide a little bit, largely focusing on our Black African population. Okay, thank you. That's my slides, and I'm very happy to take questions. And thanks to Lizzie for helping me with my lack of technical Zoom ability.
Thank you so much, Bex. And sorry about your cold as well. I can see Brian's got his hand up. Brian?
Yes, Bex. Just a quick one. You might have mentioned it during the presentation, but have we got any sexual health clinics, physical clinics in Bracknell Forest?
Yes, so thank you for your question. The one Bracknell Forest has Skimpard Hill, which currently is open 2 days a week, although the hours are quite limited. In the new sexual reproductive health service specification, which will take effect from the 1st of July next year, one of the things we've asked the specialist provider to explore is the opening times and opening days of the week of the clinics to make sure that people can get access geographically where they want it. And as I say, that's going to be done alongside exploring the digital offer so that those coming into the physical clinics are those with higher, more complex needs or needing urgent care.
Because obviously with sexual health, there's a potential for people being exploited. And we know that some gangs, when they're exploiting people, use the sexual health clinics rather than GPs and that, because it's very fairly anonymous. Are we satisfied that those clinics, well, we haven't got much of a clinic at the moment, the clinics will have an understanding of the potential for the exploitation of the people that they're actually working with, especially some of the youngsters?
Yeah, I mean, the specialist clinics and the staff working in them are our local experts. And regardless of the site, so some people prefer to access a sexual health service that's closer to where they live or work or study, but some people actually prefer to travel further for reasons of anonymity. There are risks to things like safeguarding. I'll give you an example. Because at the moment, when people access emergency hormonal contraception, so if someone goes into a pharmacy and has a young person and has a consultation with a pharmacist, they could be going to multiple sites, not just within Bracknell Forest. And again, that's where something around this provider collaborative could be quite helpful. It's not the wording we use, but basically having a network of providers where things like safeguarding might be better picked up. But some young people, yeah, there's not a single record. So basically what I'm saying is they could be taken to other sites, or could be going to other sites, but certainly in the specialist sexual health settings and any service we commission, they are all trained in acknowledging the needs of young people and spotting signs of exploitation.
Thank you very much.
That helps. Cheers.
Thanks, Brian. Hema, you've got your hand up.
Yeah. Well, thanks. That's really good example of an HNA. I just wanted to ask two observations. One is where you showed ethnicity, but it was across the 3 local authorities. It was combined. How much of that is skewed by the population in Slough, because they have a higher diverse BAME community compared to others? And I wonder whether you could break that down by ethnicity, by local authority. So it may be, that it's skewed, that low uptake in BAME communities through Slough. The other question I had was in terms of when you look at the online testing and the increase in Slough clinics, combined together, that could also reflect increased demand rather than one, or because if it was the other way around, you would see a decrease in the other. So I'm just wondering that we need to think about whether it's just increased demand. And online testing, we know also from other areas, and evidence is that populations, LGBTQ, BAME communities, others are more likely to take up online services for STI testing. So I think maybe a little bit further investigation into that would be useful.
Yeah, so on ethnicity, I know from the HNA analysis that it was consistent across all areas, so to different degrees, but the reason I've presented it in that view is that was the broad pattern in terms of certain ethnic minority groups more likely to access a specialist setting and lower uptake overall among our Asian women. And because we compared it with the perinatal equity strategy work, we know that there is, as I say, we need to explore more what's going on there to make sure the offer's a good quality one. And then with the STI consultations, yes, I take your point, and there's other ways we've split the data, we've looked at proportions, etc. What we don't know is why the number of people accessing Skimpard Hill and the Reading site has reduced since the pandemic, and that's why I was asserting it could just be that some of the people that would have gone to those sites before are now going online. But yes, we will be exploring that further, but so we can better explain what we're seeing.
Sorry, thank you. Thanks for that. Nicola?
Hi, yeah, thank you. Such a good presentation, Bex. I've been along this journey with you, I think, so I've heard you speak a few times, and really useful to see the value of data to support comments. I just wondered that clearly we know now that we've got some inequalities in accessing services. I wondered if you're also doing work on understanding why we have those inequalities, so what's driving it. So because it's only by understanding those that we can then put in things to reduce them.
Yeah, thank you, Nicola. So I mentioned at the start that we intended to do the HNA as a 2-part exercise, and that was partly because we knew from the outset that a blind spot really was the extent to which there are inequalities. So we've used part 1 to help pinpoint some areas of focus. And now the second phase is going to look to do some more detailed engagement. So I've mentioned we've started work with children, young people to understand their beliefs, views. We did some of that work during the health needs assessment. So something I didn't mention is we worked with BPAS to do a survey. It was a snapshot survey of women accessing termination of pregnancy services locally, and also we used the Maternity Voices Partnership. So that's, you'll be familiar with it, I think, Nicola, but for others, basically women having a baby in Frimley can get access to this MVP network where they can be consulted and share their views, etc. And some of the things we wanted to explore there were things we'd seen nationally, like is an issue of reproductive autonomy. So are people feeling they're allowed to choose if and when to have children, or if and when to use contraception, whether people felt there were barriers to access to services, etc. And the headline from that work is reproductive autonomy didn't come through as a prominent issue in those forum. A really small percentage reported that was a challenge, 6% of a sample of 61, for example. Some people alluding to things like beliefs, myths around concerns about contraception, and I think that's something we could work on, but I think we need to go further and do some actual outreach work with specific ethnic minority community groups, for example, on the contraception issue, because they will have very different views, and there might be very different issues. So yes, that's why we took this approach, and that is an intended part of our work going forward. So thanks.
Okay, thank you so much for that, Bex. I'm aware of time, so unless there are any more questions, I think we'll move on to Brian's report from the Bracknell Forest Safeguarding Board. Thanks again, Bex, and over to you, Brian.
Thank you very much. I had my camera off because I've aggravated my Achilles, so I have to walk around half the time because I can't sit down for very long, so I'll just sit down again for you. Thank you very much for inviting me today. Really, you've had a copy of the annual report, and a number of you are actually on either the board or the partnerships, so you've been fully involved. Really, all I would like to highlight really is that the partnerships are working very well. I'm very impressed with the partnerships, and I think from the meetings we have, there's a lot of collaboration. I think the main thing last year really was the peer review, which bearing in mind that this joint board wasn't set up till 2019 and then ran straight into COVID and everything else, is that I think it was important to have the peer review last year. And the peer review actually confirmed that actually a joint board was working well, and it was a good thing. And in fact, the peer reviewer, who was very sceptical about the joint board, was very taken aback by the work that happened between the two and the collaboration. And I think her fears were that children or adults, one or t'other, would be forgotten about. And I think actually when we look at the partnership meetings, which a number of you are here, is actually adults do sit with children and children sit with adults, and actually talking about them as a whole makes an awful lot of difference. So really the peer review. Other things I haven't really major things is that obviously we had a good, as Gronya's already mentioned, there's children's services, social care, had a good Ofsted in terms of their services. So that helps, and there was some good feedback there about the partnerships. So actually that also evidenced the partnerships we're working within the children's world. Most of the pressure, we've done a number of reviews, as you will see, and we keep learning from the reviews, and there's a lot of work that's taking place with the reviews. And they keep going. I think the major problem and the major area that's affecting all boards at the moment and all agencies at the moment is the pressure of finances, staffing, recruitment. And I have to say, as a chair of a board that looks at all these, is for the first time in my career, it feels very vulnerable to everybody. It's not just one board, it's not just one agency that's struggling, it's all agencies that are struggling. So I think that's a major issue that we keep an eye on. Really, as I say, I think that everybody's worked well together. We've had a number of seminars, had 2 last year. One was raising awareness of hidden harm and support of carers, and the cost of living one in November. And we've had one in the last 2 or 3 weeks about trauma, and they're very well attended. There was 130 there at the last one. So the message is going out. The subgroups are working well. The community engagement group has done a lot of work around working with the community, and they've done a lot of publicity around what good looks like, so that people are aware what good looks like when they're going homes and things like that. And there's an awful lot of work going on. really, you've seen the report. I've no intention of going through the whole report because it's a very long report. I do take on board what Susan said earlier about the readability of the report or the accessibility to the report, and I'm sure she's probably going to come back to that. And I think for the future years, we will be looking at a format that I'm sure that somebody will be able to give us a format that helps, that we can put all this significant information into a format that can be read easily. What I would like to do is thank all the partners for the work that they've done and supporting each other. And I'd like to support the business team as well, because I know the business team do an awful lot of work for all the partners, probably over and beyond what many do. And they're the ones that make this work. We've got a new strategy for 2020 to 23 to 26, which is roughly the same as the previous one. One of the things that we did have from the peer overview was to make it clear as to how each of the subgroups now work with each other, how the information flows through and how you get the outcomes. And to that end, we've got a performance framework, which we're sort of starting to finish off now, and hopefully will be rolled out, which has actually pulled a lot of this together, and we've restructured slightly to pull a lot of this together. The other thing is, it's very important for the safeguarding boards to work with things like the Health and Wellbeing Board. We've seen the plans, children's plans, which are important because of aspects of safeguarding on everything most people do. So actually it's important that all the boards work together and support each other. We do a lot of work with the Community Safety Partnership, obviously, because otherwise we'll want to reduce duplication, because otherwise we end up duplicating things, and that's a pointless exercise. So really, that's the review. That's my overview of the report. I'll take any questions, really. I don't want to delay you any longer. Andrew.
Thanks, Brian. That's great. Just a question at the end where we talk about how partners have contributed to the strategic plan. There's a long list of partners.
Yeah.
So I suppose a question, are there any partners that you'd like to see on that list that aren't there now? And maybe a question to some of you about where do schools fit into that? Are they picked up through Bracknell Forest, or is there another mechanism for them to contribute?
Well, they contribute. They're partners. We've got a head teacher from the primary and secondary on the partnership group. Education is obviously represented at the board with Grania and the team, and we work very closely with Grania and the team. And I meet with a lot of the education people anyway. So education is very important within that structure. But as I say, as far as other partners, we keep discovering them as we go along. What we find is we've invited several other partners. I think Mind is one that we're going to invite. Probably we keep discovering as we go through. Somebody suggests another partner that sits there, and we invite another partner. I think the difficulty is a little bit is with some of the bigger partners like probation. They're under tremendous pressure, and the ambulance service and things like that. They're more difficult to actually engage now because they're reducing their attendance at a lot of the meetings.
Great. Thank you.
Grania.
Yeah, so and just to add Andrew, Brian, there are a number of strategic partnerships within Bracknell Forest, as you'll be aware, and so the priorities have been clearly outlined as to which of the strategic boards leads on what topic area, and that helps to reduce any duplication, both in terms of the focus of the topic, but also the individuals. And the way that the board is structured is that we have what is in essence an executive, primarily the statutory partners who sit on the actual board, and then the broader partnership enables that richness of conversation, discussion, and exploring all issues. So there's real benefit. And the subgroups are very, very effective. So in terms of what they actually deliver and content and documentation, etc., with everybody working together with that leadership. So, and then those things then come up into what is the Bracknell Forest formal board to us.
Thank you. Tessa. Tessa?
Tessa, you're on mute.
Sorry, I leant on my mute button on my headset and switched my mute button back on again. Sorry. So I was just going to build on, somebody has to do it, don't they, in every meeting? So I was just going to build on that kind of formal partnerships and us all kind of working together, really, because I chair the Child Death Overview panel, and I'm really pleased to see that some of the work that we've been working on in the Child Death Overview Panel is sort of reflected in the safeguarding annual report as well. So I think it's a real strength, and something that we need to build on further, so that we make sure that all the learning that we're extracting out of the Child Death Overview Panel feeds seamlessly into the safeguarding arenas as well, because the panel runs pan-Berkshire and feeds into all the different safeguarding arrangements across the county. But really good to see that it gets a good mention in the report. So thank you for that.
Well, we do a lot of work around the reviews. We're very good compared to some places. We do a lot of work, and we're learning a lot as well. There's one going on at the moment with FII, which is a very detailed review, which is going to give some national learning as long as local learning. But obviously, to a certain extent, we also want to be aware of what's happening within the CDOP, because of the messages that go out, and you will see that some of the messages that have gone out, safe sleeping, water safety, etc.,
water
etc.
safety,
and that's coming directly from the reports that you're producing, to say that there is an issue. So if there's a Pan Berkshire issue or a East Berkshire issue, we will introduce it as well as a local issue to have a prevention system before it starts happening.
Yeah, that's great. Thank you.
So Brian, just you mentioned FII, because this is a public meeting. Do you want us to say what FII is?
Fabricated induced illnesses. It's the issue where people are turning up at hospitals, or children are turning up at hospitals with a potential fabricated or induced, possibly by parents. I won't say too much on it because I think Coronation Street's got it on at the moment, is the FII. But it's an interesting one because they're turning up at, there's some children that are turning up, and adults as well, that are turning up at several hospitals over a number of approaches over a number of periods of time. And I had an FII on in another area where children were being operated on because mother insisted there's something wrong and they needed an operation. She was very knowledgeable, and they were operating on kids that didn't have anything wrong with them. But they were turning up at 200 times a year at hospitals. But there was no system to link them together. There was no professional curiosity. And interesting enough, there's a report that's just come out, which the board of the team have just alerted me to, which contradicts, basically, it's a research from a university research, which says that fabricated illness doesn't exist. It's a bit like the shaken baby a few years ago. It doesn't exist. It's and people who are identifying fabricated illness are actually challenging parents and are abusing parents. So it's one of those issues that actually it's a very difficult one for a professional to actually say, because they're making some quite serious judgments against some people with serious consequences. But this one will be an interesting one, but there's a court case with it, so I can't say too much. But it hasn't stopped us putting out a briefing sheet about what we found, which is anonymous, so it actually doesn't affect the review itself. But I think it's those sort of things that are difficult, and we work very closely with the hospitals as well. We work very closely with Frimley Park, and get good support. Get very good support from the local police as well. I have to say, we're very fortunate compared to some boards. Is that with the new command structure and Andy Granage and Matt Darnell and things like that, they're very supportive and very much involved with the boards, which is great.
Thank you, Brian. Any more questions? Okay, thanks for a great report there. And so if we just go on to, I think it's our final agenda item with regards, oh no, and then we've got AOB and there's something on that as well. The forward plan. So I think this was just for everyone's information about the plan for meetings for next year. Has everyone managed to have a look at it? And are there any comments?
Yeah, it's just a query whether anyone's got anything they want to put onto the next agenda as well, so that we just try and build the agendas in advance so that we've got time to prepare for them. So if anyone's got any ideas or things that they'd like to bring next time, then to either let us know now or let Lizzie know in the intervening period.
Okay, just on that, Sophie Wing-King from the Domestic Violence Strategy people, she's got a report that she wanted to share at the Health and Wellbeing Board, and I don't know if that's the right place or if it should be at Place Committee. But anyway, she'd sent it to me, and I got it like the day you were doing the agenda setting, and I didn't open the email in time, so I said I'd let you know for next time. So
Okay, we'll pick that up with her directly. Thank you.
Okay, thank you. Thanks. Sue?
Thank you. It was a question for Nicola on whether we thought there might be anything suitable at the next meeting stage to reflect on the new, new structure for the ICB, and whether there are any opportunities that fall out of that could usefully be brought to the Health and Wellbeing Board. Might be too early, and I accept that, but
so I'm not. So as you know, I think it might be the AOB. I think it might be the February meeting, Susan, rather than the January meeting.
Is it?
That would be useful.
Okay.
So,
lovely.
but yes, and I can work with Andrew or whoever about what would be the right meeting to bring it to.
Okay, thank you. Anything else for upcoming meetings? All right, and then AOB. Andrew, do you want to talk about the Frimley consultation?
Yeah, just to say, I'm hoping that the link works, but in your agenda, there's just the link to the new Frimley Hospital. So there's a consultation at the moment. Frimley is going to be rebuilt, likely to be off-site. So there's a consultation that's ongoing with residents, etc. For Bracknell Forest residents, if they want to talk to someone directly, then on the 13th of December in the Bracknell Town Centre between 9:30 and 2:30, there is an opportunity for the members of the public to talk to the Frimley team about what that looks and feels like, and or what the next steps in that process are. But the link there should work. If it doesn't, then we can recirculate it.
Thank you. All right. Okay, any other business? Oh, right, Nicola, sorry, your hand's up.
Yeah, sorry. So just to follow on from Susan's comment, just for anybody who doesn't know, Frimley ICB is currently also going through a consultation about its structure going forward. I believe that paperwork should have come out to you as key partners, and that Andrew is coordinating a response. So if anybody wants any further information that don't know what I'm talking about, then let me know. But I think, Brian, you should have received that with your safeguarding hat on as well. We're expecting the outcome of that to come back out again in terms of any changes to the structure towards the end of January. So that's why it might be appropriate in February to be able to talk about what the future operating model might look like, etc., etc.
Sorry, I got interrupted by my son. Thanks for that, Nicola. Okay, any other business? All right. Thank you, everybody. It's 13 minutes to 4.